Hi, everybody. Today we're going to talk about global models of healthcare systems. This class will help you to compare the organization, structure, and function of healthcare, public health, regulatory systems across national and international settings. Specifically, we're going to talk about the organization of healthcare systems globally, and this should help you to describe how we organize our healthcare system in the United States. Now, the basic goals of all healthcare systems are threefold. First is prevention, to keep people healthy. Second is treatment, to provide care to those who need it. And third is protection from catastrophic financial costs, to protect individuals and families against financial ruin from medical bills. Healthcare systems have other goals that can be more aspirational. To strengthen social empowerment, healthcare systems can seek to influence the social values, norms, and practices of government, to promote trust and cohesion, and to promote the idea there is a public responsibility for health. Healthcare systems can seek to have intersectoral action on health and serve as an anchor and platform for the idea that health should be in all policies, and we should be looking at the impact of health on all policies. And finally, to look at closing differentials in vulnerability and consequences, that eliminating inequities and creating equitable financing for patient-centered care should be a goal of every healthcare system. There are four main healthcare models that we'll talk about today. First is the National Health Service model. Second is the Social Health Insurance model. Third is the National Health Insurance model. And four is the out-of-pocket model. The National Health Service model, otherwise known as the Beveridge model, was first developed by Baron William Beveridge of the House of Lords and implemented by Nye Bevan of the House of Commons and a Minister of Health in England post-World War II. In this model, healthcare is provided and financed by the government through tax payments, just like the police force or the public library. Most hospitals and clinics are owned by the government. Now, some doctors are government employees, but in this model, doctors can also be private doctors who will collect fees from the government using a set schedule. In countries that employ this model, there are no medical bills. Now, there may be small copays for some services, but in general, these systems have low per capita costs because the government is the sole payer and controls what doctors can and do, and what services can be provided and what can be charged. Countries using the Beveridge plan include the United Kingdom, Spain, Finland, Denmark, and Cuba. The next model seen globally is the social health insurance model. This model was developed by the Prussian Chancellor Otto von Bismarck. This is an insurance system. The insurers are called sickness funds, and they're usually jointly funded by employers and employees through payroll deduction. For people who are not working, the former employers will sometimes kick in money and the government will provide funding. Unlike in the US, however, Bismarck-type health insurance plans have to cover everybody and they can't make a profit. So in this model, both doctors and hospitals tend to be private. Insurers are also private, but they're not for profit. This is a multi-payer model. Germany alone has about 240 different insurance funds. But what keeps it organized is tight regulation, and this gives government much of the cost control clout that the single payer Beveridge model provides. And some countries using the Bismarck model include Germany, France, Belgium, the Netherlands, Japan, Switzerland, and much of Latin America. Now, the National Health Insurance model has elements of both the Beveridge and Bismarck models. It uses private sector providers, but payment comes from a government-run insurance program that every citizen pays into. This is also known as a single payer model. So essentially, the government's the only source of health insurance. These universal insurance programs tend to be cheaper and much simpler administratively than American-style for-profit insurance because there's no advertising, there's no competition, there's no gimmicks, there's no huge salaries for the heads of the companies. They typically run at a 4 to 6% overhead. The national health insurance model, or single payer, has considerable market power, so they're able to negotiate lower prices with healthcare providers for services and for pharmaceuticals. National health insurance plans also control costs by limiting the medical services they'll pay for, or by making patients wait to be treated. Countries using this model include Canada, Taiwan, Nigeria, and South Korea. Now, shared characteristics of these three models are that they are centrally organized and regulated by the national government. Whether the insurers are public or private, the rules and regulations they have to abide by come from a central agency. They're primary care focused, they provide universal coverage, there's integration and coordination between different parts of that healthcare system. There's a focus on cost containment, on ensuring quality of care, and again, on integration and coordination of systems. Now, in the out-of-pocket model, people simply pay for care when they need it. If someone can't afford care, they don't get it. Many less developed countries use this model in practice, even where government systems exist for part of the population. And the United States also uses this model for a portion of our population. So you might be wondering, what models does the US use? Well, we use all four of them, depending on who you are. We do have something similar to the National Health Service, and that's both the Veterans Administration and the Indian Health Service. In those cases, the hospitals and clinics are all government owned, and the healthcare providers are all government employees. Any veteran can seek care at a VA hospital or VA clinic, and they pay very small copays for that. We have social and health insurance. Most U.S. residents who are employed get their insurance through their employers, and this has increased since the Affordable Care Act in 2010. We also have national health insurance. So we have a kind of health insurance where the government is the only insurer, think Medicaid and Medicare. Medicare is federal insurance for those age 65 and over and for some disabled residents. It's payroll funded. We all pay into it. Medicaid is government insurance. It's a federal-state partnership, and it's funded through general tax levies. And finally, we have the out-of-pocket model for the roughly 9% of U.S. residents that are not insured and for services not covered by insurance. Now, a big question that is asked globally is, how should healthcare systems be structured? And in 1978, there was a meeting called the Alma Ata meeting, and there was a declaration. And what I really like is the quote from the leader, the architect of the declaration. So I'm just going to read the first part and let you read the second on your own. Unless we all become partisans in renewed local and global battles for social and economic equity in the spirit of distributive justice, we shall indeed betray the future of our children and grandchildren. And the Alma Ata Declaration had a number of suggestions for how healthcare systems should be structured in order to bring about health equity. First, that primary health care would be the center of the system, that primary health care would be the first point of contact, and that we'd bring healthcare as close as possible to where people live and work, and that we'd expect primary health care to address main problems in the community. That minimum services provided would be nutrition, safe water, sanitation, maternal and child care, immunizations, prevention and control of local endemic diseases, appropriate treatment of common diseases and injuries, and the provision of essential drugs. Further, that primary health care would promote individual and community self-reliance and allow participation in healthcare decision-making. That this would be universally accessible to individuals and families in the community. There'd be full participation and the cost would be affordable. And that this would be sustained by integrated, functional, and mutually supportive referral systems, which gave priority to those most in need. And finally, that primary health care and the healthcare system would lead integrating health into all systems, a health in all policy approach, and would demand and coordinate efforts to promote health in all policies. So I'd like to leave you with this thought to just really think about how does our structure of our healthcare in the U.S. compare to the principles set out in the Alma Ata Declaration. Until next time.